Stephanie's in her 25th year of athletic training. She has had the opportunity to work in a variety of settings, exposing her to new and innovative ways of treating athletes at all levels. She currently works for SMASA, where she is assigned to San Antonio FC, a USL team in San Antonio, and is the internship coordinator for kinesiology and health senior students at UTSA. In addition to her LAT, she is M1 certified in Greeson, Impact trained athletic trainer, and AHA HCP CPR instructor. Please welcome Stephanie Greeson to Spats, everybody.
Oh, I have the microphone on me, thank goodness, because I'm a wanderer when I speak in front of individuals. I'm a very kinetic learner. I'm a kinetic observer, and I like a lot of interaction. I'm going to try to introduce a new approach when dealing with athletic injuries, but even that, I feel like what we will learn today will be something that you can incorporate in your own lives. First and foremost, I need everybody to get into groups of 4 or 6 and come up and get some of the items. Sorry, I'm getting feedback. Some of the items that are up here on this table, okay? I'm going to have some help today. Ansei Atanga, she's an athletic trainer at Grapevine High School. She's going to help me do some demonstrations. If you have any questions as we go through, I really would appreciate you guys interacting with me. I'm not used to just lecturing and having a very silent cricket type audience. So as we're getting into these groups, with a show of hands, how many have you guys ever heard of PRI, or Postural Restoration Institute? PRI, which stands for Postural Restoration Institute. So we have a couple of people. One of the things when approaching athletic injuries, especially when we're talking about the lumbopelvic region, anytime our athletes come in with low back pain, one of the things that I notice a lot of us have done or do is we go immediately to tight hamstrings, hamstring inflexibility. So what I want to present to you guys is a different approach when dealing with any type of hip impingement, SI dysfunction, pain, low back pain, tightness, anything in that nature. I would like to present to you guys a different approach in dealing with that. So how did I get here? Well, as mentioned in my bio, I've been an athletic trainer for over 25 years. In that time, I've had the opportunity to work with a variety of healthcare professionals and all levels of athletes. In that time, I have gotten to learn and experience so many different thought processes as we approach injury. Currently, as stated, I am on the UTSA faculty. I am the wife of Jerry Greeson, who's the head athletic trainer at UTSA, and I'm the mother to Curtis, who is now a graduate. Woohoo! We made it. All right. But most importantly, as I stand here in this role today, I want you to know that I love what I do. And I think the reason I love what I do is because you never know what you're going to get when it walks through the door. I'm a person that loves puzzles. So when you are facing an injury, when you look at it like you have a puzzle to solve, that is always exciting to me. So first and foremost, what is postural restoration? The concepts have been around for many years, mainly in Eastern medicine, Asia, but Ron Haruska has spent his life work in developing and bringing together these concepts, which is the Postural Restoration Institute. He is the director. Their mission of postural restoration is that they want to establish and explore the science of postural adaptations. Why do we adapt to get a movement done? They like to present innovative treatment to look at getting the posture in an ideal position before you start dealing with movement. There are 3 main courses that you can take in this course. There's also supplemental courses. You can become PRI trained for athletic trainers, strength coaches, and things like that. You can also be PRI certified, which is your PT, OT, and other healthcare professionals in that area. Please note that I am in the process of getting my completing my training. I am not trained at this point officially. I will be soon. So what I'm going to be talking to you about is I want to introduce this concept, and if this is something that you really do find interesting, then we will give you the opportunity to know how you can go about getting this training. With a show of hands, are we symmetrical or asymmetrical? Who believes we're symmetrical? We're absolutely asymmetrical. Thank you. We had one participant. Woohoo! Anyway, in our asymmetry, are we able to be balanced? Yes or no? Yes, absolutely. All of our body systems are asymmetrical, which we cannot change that. Even though we may be right-hand dominant, left-hand dominant, the thought process from PRI is that humans are typically right-side dominant. Now, they subscribe to 4 basic principles. Sorry. If you look at it, humans are asymmetrical, which is what we just talked about, but let's take that a step further. The brain, the left side of the brain, is more fully developed than the right side, which the left side controls the right side of the body, okay? Our liver on the left side of the body can weigh 3 to 4 pounds, whereas the spleen on the right can weigh maybe a pound. So as you go through this, no matter what dominant hand you are, the majority of us, 99% of us, are right side dominant. Now then, there are certain situations where your organs can be switched or flipped in your body. That's rare cases. And with that, they may subscribe that you are left side dominant, but it's more likely that you are right side dominant. Now, there's a couple of chains we will talk about. Today, I'm really going to be focusing on left anterior-interior chain, but there's also a posterior-exterior chain. These polyarticular chains connect our diaphragm to our knee. Ron Haruska made an attempt to actually dissect our hip flexor from our diaphragm. Actually, he took 17 cadavers to try to dissect. He was 0. He wasn't able to actually truly dissect our hip flexors from our diaphragm. So while we go through this and while we work on our positioning and we do some of the activities today, you will see that that chain is very much tied to our diaphragm. And our diaphragm is in charge of what? Breathing, absolutely. Now, one of the big things is position, position, position. If you are trying to get an athlete to perform a movement, okay, ideally you want them to do that movement correctly and in the proper position. But the majority of us, being right side dominant, have a very difficult time actually getting in that left side weight bearing. So I want everybody to stand up right now. Okay. We're all standing at the mall, we're talking. I want you guys to kind of get in your normal stance. Everybody's in their normal stance. Which side are we putting our weight on? Even if we're standing equal, which side do you think the majority of your weight is? Okay, some people say left, okay? We're going to do an activity here in a little bit to actually demonstrate, okay, y'all can sit down, that it's very difficult for us to get in that left AIC. So we talked about position. The fourth principle is never underestimate the power of respiration has on position, okay? When we typically have an athlete do an exercise, we either have them do sets and repetitions, right? Or we might have them do it for time. What I would like to challenge you is when you are doing these activities, instead of doing repetitions in time, that you focus on their breathing. Good breaths. Because, again, the position is very directly linked to respiration. So again, going back to our body's asymmetry, okay? If you will notice on the presentation, you can even see when you were looking at the diaphragm that which side is supported and more structurally sound, that has support structures around it. Which side? Left side or right side? Right side, perfect, thank you. So going back to our liver, okay, being on our right side, all of this is pushing everything up into our diaphragm. Can everybody see? Everything is pushing up. So our diaphragm has structure, so it kind of has something to push off of and give that good breath. The majority of us, okay, are what we call external breathers. When we breathe, okay, we take big old breaths and our rib cage extends this way, okay? So when we're doing these activities, I'm going to keep talking about respiration, but first and foremost, let's go back to our body's asymmetry, okay? One of the things as we go through this, we talked about being right side dominant. But the problem is the majority of us are over-dominant on that right side. Because if our right side is dominant, then our left side was like, well, if they're going to do the work, I'm going to kick back. Okay? So what we're going to do is with left AIC dominance in that polyarticular chain, we're going to have to utilize, our thought process to really extend and strengthen this left side. And a lot of it comes from strengthening that left side abdominal, your external obliques and so forth. Now, again, with the polyarticular chain, here are the muscles that make the interior chain, the AIC. Our diaphragm, which is king. It's at the top. It rules everything, okay? Our iliacus, our psoas, our TFL, our vastus lateralis, and our biceps femoris. Again, this connects our diaphragm to our knee. So when utilizing PRI with your clients or yourself, there are 3 goals that you need to keep in mind. Reposition. You're going to need to reposition somebody, okay? Which means you're going to have to work on inhibition. You're going to need to retrain, which is tied to facilitation. And then you're going to restore that symmetry and that perfect balance, okay? So, when you are in a right, Ansei, I'm going to get you to come up here. When you're in a right stance, okay, go ahead and put your left foot forward. Okay, left foot forward. Okay, and shoulder like you were going to stand. Okay, put all your weight on your right foot. Okay, so right here, when you look at her, okay, her pelvis on her right side, okay, when we are weight bearing on our right side, it is shifted forward, externally rotated, okay, and then you get external rotation in that femur. Right? Okay? Now, I want you to switch legs. Okay? Put all your weight on here. Now, did it look like her pelvis changed any? Let's do that again. Switch. Okay, so here she is here. And what is she doing? She's leaning. Okay, so let's come right here. Ooh, got a little pop there. Okay? I'm actually holding her in a good position, but do you see how she's really unbalanced? Okay? Now, I want you guys to kind of partner up and actually do this with each other, okay? So I want you to hold their pelvis, okay? Get in that right stance, okay? And then I want you to have them shift to the left stance. Thank you.
That's right. Like, maybe I like lean, but when I get to the other one, I don't necessarily lean to my left. I just
So one of the things you'll see, and Ansei really brought this up, is she said, you know, when you're in that right side stance and you're leaning basically to the right side. Our torso is coming to our right side. But when you go into the left stance, where's that torso going? Did it change? Now, I'm exaggerating a little bit because I've been working on this with myself. Okay? The majority of us, when we shift to that left side, we are still leaning to our right, correct? So I want to challenge, is our weight truly on our left side? No. All right. Thank you. We'll come back to you. All right. So, pelvic position, left AIC, okay? Our left side is going to be forward flexed, external rotation, and abduction, where our right side does the opposite, okay? Where our right side is whatever our left side does, our right side is going to do opposite. So, right side does the opposite, extension, internal rotation, and adduction. So, take the volleyballer, the 7th grade volleyballer, and have her do 10 block jumps. You will see that the majority of her jumping is going to initiate from the right side. And as she does those block jumps, that left knee is going to internal rotate, correct? So it's like their knees do the clapping. The majority of the time. If you even some of your high school players, get them to do 10 block jumps and see how many can do nice and equal position. All right? I lost the pointer. So, oh, we just did this. Sorry. I got ahead of myself. As we go through this, we're going to be talking about positioning, but how many of you guys, right after an ACL reconstruction, have to retrain gait? They get that hip swing, correct? So when you're working with those individuals, okay, how are you going to get them to, when they're walking, okay, even when people walk, they tend to lean to the right side, okay? Now, I've exaggerated that because I want you guys to see. Now, it's important also when we're looking at the AIC pattern, the other polyarticular chain is the PEC, okay? And I want to kind of get Onse right here to stand up. A lot of times when we know, we feel, okay, I'm going to have you stand sideways. Okay. So Miss Onse, I'm going to pick on her a little bit, okay? So with PEC positive is you'll see that extension in their back, correct? Okay? You'll see that what's happening to her pelvis and her pelvic floor is she's rotating downward. So you're getting that shift with the pelvis. So right here with Miss Sassy here, she drove in the front seat with me down from San Antonio. I had to do most of the driving. We didn't get very far when she drove. The no arms and everything. I still had to steer. All right, so when you're looking and can everybody see the pelvis? I know it's not ideal. But when you're looking at somebody that's right side, and Sassy is very right side right now, okay? So as you shift forward or back and forward, you're going to have that right hip, okay, go into what? So when you are in right stance, okay, let's go back to the left AIC. Right hip is going to forward flex, externally rotate. We're talking about this portion of the hip, which is the ilium. So you're going to forward flex, and then you'll externally rotate. So when you externally rotate, this left leg, which I had to put this left leg on her because she didn't have a left leg. So what happens is the femur externally rotates. But on the right side, you're not getting that. You're getting internal rotation. You're getting shifting back and internally rotation. Okay? So to compensate, a lot of us, what we do, and just to kind of point out here, so again, when you see this overextended back, what are you seeing with these muscles right here? What's happening? They're getting shortened. They're getting tighter, right? So when you go to the front, the psoas, all of that is becoming more open and facing downward. Okay? Now, go ahead. You can sit down for a second. So going back to gait, people that have PEC, okay, whoops. When you go to sit down, people that have a PEC, okay, when they sit down, what's happening? Are they actually sitting on their tailbones or their sit bones? A lot of us will shift forward. And to compensate, some of us will kind of do the forward rounding. So how can you train somebody in gait when they can't get their position, their pelvic position in the correct space, in the correct area? So when you are assessing neutrality, I want you to take a look. So we've got this UTSA football player, he that may not be named. If you will look at that front foot, okay, It's externally rotated, correct? If you will look at the soccer player, look at the extended foot, look at the femur position, external rotation, okay? Now, let's look at this bull rider. One of the things, I know it looks like the extended leg is the one that may be in the actual undesired position. However, it really isn't. If you will look, and it's kind of hard to see, but the leg that's closer to the bull, look at the foot position. You see external rotation, okay? So these individuals, okay, soccer players, at certain positions, when you see them walk, they're walking toes out, okay? They're kind of hunched over, shoulders. All of this right here is crowding our diaphragm, okay? Now, there are two different types of tests. There are actually 4 tests that you can look to assess left AIC and PEC, but we're really only going to do 2 of those tests. So I know that you guys are kind of in some groups right here. I'm going to get Miss Onse to come lay on this table and lay on her side, okay? Now, if we're going to test both sides, and I'm going to demonstrate first, okay? This is going to be a modified she said you could lay on that table. All right. First, we're going to watch. This is a modified Ober's test. Maybe. You can lay on your back for a sec. I did, and it opened it, but it's not playing. Technology is not my forte. I'm sorry.
Was it already open before? I think she had it open. I don't see anything there, so I don't know if the internet.
It worked yesterday and today.
He's gonna get you real quick.
I try. Thank you. Yeah, it's talking.
We are going to be going over something called an Ober test to assess tightness of the lateral thigh. But what I'm going to show you is that it's not always tightness associated with the lateral thigh. Now, some people call this an IT band friction syndrome. All you runners out there know exactly what I'm talking about. Sometimes you get pain in the hip or pushing the lateral knee. So you begin this stretching for this muscle called the IT band or the tensor fasciolateral. Well, guys, it's probably not the muscle. In fact, I rarely run into a tight IT band. What I do run into sometimes is a neurologically active IT band, meaning it's busy, but it's not tight. But more often than not, it has nothing to do at all with the IT band and everything to do with the position of the pelvis and inactivity of abdominal obliques on the left side. So let me show you what I'm talking about. We're going to do something called an Ober test to assess what we've all learned as IT band tightness. So I'm going to hold Sarah's hip in place, bring the leg back, and we're going to see this leg kind of hanging in midair, sort of like a diving board. So this would be a positive test. Now what we're going to do is we're going to begin an intervention here, to help Sarah reposition her pelvis. So I'm going to place a little roll between Sarah's knees, bend her hips and knees up, and I'm going to say, all right, Sarah, what I want you to do is gently squeeze down into this towel,
And then when you take a breath in, I want you to slide your hip back while you squeeze. Inhale. Exhale, drop your ribs and your knee and squeeze. Now what Sarah feels is lighting right here. This inside thigh muscle is engaging, which is changing the position of her pelvis. Now Sarah, ready? Take another breath in. Shift back and squeeze down and hold. Abs are on, inside thigh is on, pelvis is moving in one direction and another direction at the same time. Last breath in. Breathe out, squeeze down. And hold right there with a squeeze here and some ab activity right here. Take a last breath in, I lied to you, and relax. So all Sarah really did was change the position of her pelvis using a muscle on the inside of her thigh and using her abdominal oblique muscles. So I'm going to borrow her leg, we'll bring it back, and we'll let this leg go. And golly, all of a sudden this leg now crosses midline. Isn't that amazing? And so we care about this because as a runner, if you can't isolate your abdominal obliques for trunk rotation when you run, and this adductor muscle on the left for hip shifting to the left when you run, I don't think you're going to run very well. And that's what you need to keep in mind because it's not an IT band. It's all about position of the pelvis. Thanks, and we'll be checking back with you soon.
All right, so when we're assessing, I like that video. One of the things I will show you what the PRI concept, they do an adduction drop test. But here, what we're going to do is I'm going to assess, okay, Miss Anse here, okay? And this table's kind of hard to get them in, but we're going to put her at 90-90, okay? Now, when you do this test, it's important that you stabilize. You stabilize the hip joint. Because a lot of times what will happen is when you do this test, they roll back. And you don't want that. So as you're coming through here, okay, I'm going to bring, oh, sorry. Oh, put your leg back up there. There you go. Thank you. All right. So as we do this, okay, I'm going to bring her leg back. What's going on there? Nothing. Okay? Do you see much of a shift? Ideally, her knee should drop to the table. Okay? And this table isn't the best. So what we're going to do is I'm going to grab my little green ball here. You can use towel rolls, foam rollers, anything like that. Okay? So what I'm going to have her do is we're going to position this right here. Okay, put your leg down. Okay? Now, again, I want to stabilize, okay, that pelvic. We're going to shift this hip back, okay, shift that hip back, and I want you to take a big old breath, okay, and let it out. You want to breathe through your nose and out your mouth. One more. Make sure you're squeezing that ball. And back. Okay, sometimes you don't get a lot of movement here. So one of the things we'll have them do is you keep them in line, okay? I want you to squeeze the ball, okay? Where do you feel that firing off? Okay? Adductors, all right? So take a big old breath for me. And then as you breathe out, I'm going to push down her rib cage and rotate. Okay? Sometimes you need to give them that guide. Okay, are you still squeezing that ball? All right. Now then, take that out. Okay, now, let me move you. She's helping me. All right, so as we go back into the Ober's test, what do you see? You see that maybe it really wasn't tight IT band, okay? Maybe we're not getting that the pelvis in the correct position, okay? Now, I'm going to have you sit up with your legs forward, okay, and switch to the other side. It's always important when you're doing these tests to look at it bilaterally, Okay? So let's take you in 90-90. Okay? Again, I'm going to stabilize the pelvis. Okay? I'm going to take her back. What do you see here? She drops. She drops. So what we're seeing, go ahead and sit up, is she is positive for a left AIC, okay? Meaning it may not be tight hip flexors. Anytime you have anybody with back pain, hip pain, SI pain, hip impingement, a lot of that has to do with pelvic position. So it's important when you are approaching an athletic injury that you think it may not be tight muscles, okay? Inflexibility may not be the root cause. It might be the position of the pelvis, okay? Now then, so again, on the with PRI, they do the adduction drop test, which is, we did a modified Ober's. So we know that with her, she has that left AIC, okay? So now what we're going to do is I'm going to get you to lay back down here. Okay? I'm going to come forward right here. As we do this, okay, one of the things that you can do also is you can have them do 4 deep breaths. And I didn't bring my straws up here. I cut a bunch of straws. You can use a balloon. You can use, we get straws for when people come and cater. So we just cut them and we use that. So breathing, again, changes the position of the pelvis. So what we'll do is we'll have them breathe in through their nose, okay? Hold it, 3 counts, okay? And then breathe out through the straw. We want them to give a hard breath through that straw, and we want them to be able to push that air. Because what we're doing is we're actively engaging, especially this left diaphragm. Okay? Now then, go ahead and sit up for me. You're going to stand up. Okay. Now, in front. Okay. Now then, the second test I'm going to show you, okay, is the standing reach test. All right? So we know that, and we kind of done some modifications, but we know when we started, she had left-sided AIC. So as you turn, I'm going to get you turned to the side, put your feet shoulder-width apart, okay? And what I want you to do is I want you to put your right hand over your left and try to touch your left toe. Just bend down and try to touch your left toe. Okay, come up. Now, switch your hands. Now go over and touch your right toe. What do y'all see? So does she have a tight hamstring, or is her pelvis in a bad position? Pelvis. Okay? Now, a lot of times, go ahead and sit back up here. Another activity that we can do to correct that okay, is, oh, where's my person? We'll see if this works. Okay. Well, I'm going to wait for that because I don't want to miss. All right. So what we do is we get her back in that same position, lying on her right side. Usually we'll have a pillow under her head, okay? Now, and ideally you want her in 90-90. This table is prohibiting some of that, okay? So again, I'm going to put a towel roll or some sort. We use these massage balls, foam rollers, anything that we can make work, okay? So put your foot down, okay? Now, what I want you to do okay, and it's hard to kind of see, especially for those of you over there, is with the standing reach test, I want you to bring your top knee, okay, and touch my hand. So you're going to roll forward right here, okay? So hold that position, keep your feet together. Don't move. We're dancing up here, okay? Again, what I want her to do is keeping this knee forward. I want her to squeeze the ball, squeeze, squeeze. Breathe in your nose, hold it, and breathe out. And ideally, she would have a straw or a balloon, and she would breathe out. We do this 4 times again. Now, I'm not having to help this rib cage. She's actually really getting more movement in this left rib cage. Are you squeezing? Keeping that leg forward? Okay. Now, as we go back, we should even see more of a drop. Okay, no, just relax. Okay? She's actually going down more. We're seeing more of a drop on that. So, am I doing any deep tissue massage? Am I doing any foam rolling? Am I stretching her IT band and hip? No. All of this is we are getting her pelvis in a more neutral position. We're getting movement in that pelvis. Okay? Now, go ahead and carefully stand up. Now, turn sideways, feet shoulder width apart, cross your right over your left, go down and touch your left toe. Do you see a difference? There's improvement. Did I stretch her out? Did I do a bunch of deep tissue? Did I make her go foam roll? Did I put her on heat and stim? No. I'm taking a cold muscle and having her increase flexibility in just a couple of minutes of work. Okay? As athletic trainers, you can go ahead and sit back on the table for a second. As athletic trainers, okay, especially those of you that work in high school settings and collegiate settings, you have anywhere from 500 to 1,500 athletes that you're shuffling and doing on a daily basis. It's very difficult to spend a lot of time with these athletes. But how many more athletes could you see in a day if you correct issues with tightness, I'm going to put my air quotes, tightness, in working with pelvic stabilization? It decreases the amount of time you need to spend with each athlete. And as we get them in that more neutral position, then they're able to jump higher, they're able to run faster, and they are able to squat, lift, whatever. They're able to perform these activities. So how many of you guys see an increase in back injuries when football's over and we start off season? How many of you do? We always see back injuries. That's when we kind of see the big increase. Because a lot of us, we're pushing those heavy weights, we're getting our maxes, but our pelvis is not in a neutral position. A lot of that could be avoided if they did some type of activity, even if that was in part of their warm-up. Now, I know getting coaches to think in that term is going to be difficult. But one of the things that we've done with some of the coaches that we work with is we make the coaches come in and do that. We test them. We do an assessment. Okay? Now, yes, my thing is I have 30 athletes. There are 2 of us. So I understand that, my demand at where I'm at now is way less than where the majority of you guys are right now. But again, it's about having quality activity, not quantity. Okay? Now, so in regards to, let me see. Let's see if this one works. embedded it and everything. I went on Google and asked how to do it. That's a reference. That's it. There. It's so nice to have somebody up here running the machine for me.
We got your feet on the wall, and what I want you to do is get a little closer to the wall.
This is
And you
Ron
push down into my
Karuska,
hand.
who is
Push down and
the
feel those
individual that
hamstrings
developed
kicking, okay?
PRI.
And lift up your
And
pelvis. a
so
little bit.
this right here is a
Go back on down.
90-90
I'm
hip
put my hands in
shift.
the rib cage. Pretend like my hand is there. Take a deep breath in. Blow out the air. Raise your pelvis up. Perfect. You have that down? Okay, go back down. Do it one more time. Breathe in. Blow out. Good. Ribs come down. Back is flat. Butt's in the air. Hamstrings are on. Feel all that? Good. Relax. Now, you're going to take a balloon. You're going to put it in your mouth. You'll breathe in. Take a nice breath in through your nose. Blow out the air. When you blow out the air, I want you to pause. Remember to pause. We'll have you put your right hand above your head. You hold on the balloon with your left hand. And remember, we're trying to get air into your right chest wall. So I'll probably put my hand on your left side here so that you are reminded of that. Try to fill up your right chest wall when you breathe in. And the biggest thing you got to do is you have to remember not to breathe with your mouth air, because if we breathe with your mouth, you're going to breathe balloon air. So I'll go 1001, 1002, 1003, 1004. Nice breath in. And you take that breath in with your tongue on the roof of your mouth and take it in through your nose. Let's practice that first. Put your tongue on the roof of your mouth. Okay? Breathe in through your nose. Blow out through your mouth. Good. All right. Let's practice this once, then we'll put it all together, okay? Put the balloon in your left hand. Here we go. Breathe in through your nose. Blow out through your mouth. Now pause. 1, 2, 3, 4. Tongue up. Breathe in through your nose. Fill your right chest. Blow again. Go. 1001, 1002, 1003, 1004. Tongue up. Breathe in through your nose. Blow out one more time. This is your third breath out. 1, 2, 3, 4. Deep breath in. Pinch off the balloon with your fingers. Take the balloon out of your mouth. Let the air out. Good. Okay. And you notice that when you took that last breath in, you stopped after you took the breath in. You didn't go on. So 4 breaths in, 3 breaths out. Okay, let's put it all together.
Okay.
That go pretty well? Tongue on the roof of your mouth again. Here we go. Take a nice little tilt here by breathing in through your nose. Blow out. Roll your pelvis up in the air. Good. Jelly belly. Got her? Jelly belly. Hamstrings are on. Back is flat. Balloon goes in the mouth. Think about getting air in your right side. Ribs down on the left. Breathe in through your nose. Blow out through the balloon. Into the balloon. Pause. Count to yourself. Don't squeeze the neck of the balloon. After 4 seconds, breathe in. Good. Blow. Good. Hold it. Good. 2, 3, 4. Pause. Breathe in. Deep breath in. Tongue still up. Blow. Tongue dropped. Hold it. 1, 2, 3, 4. Deep breath in. Pinch out the balloon. Relax. Down you go. Any questions?
Okay. Now, one of the things when we're doing that activity is we want them to be able to drive their knees, drive their calcaneus, drive their heels down and into the wall, okay? When they do that, their hamstrings are going to fire, okay? The majority of us, when we have left AIC, we are actually very weak, predominantly in our left hamstring. So if you were to do some muscle manual testing to test hamstring strength, okay, you would see a discrepancy. Normally, our right side's going to be stronger. Right side's going to be stronger. All right. Now, another thing that we are going to do is I'm going to have Anse to get on the table one more time, okay? I'm going to have you lay on your right side. Okay. Now, what we would do for this activity, I'm going to get behind you. Okay. So again, you want them, I always say their feet are going to be on the wall like they are sitting in a chair, okay? And they're laying on the floor. We will put, and I'm sorry, this is not very comfortable. We would put a foam roller under their legs, okay? Now, what I want you to do is I want you to lift your left knee up. Lift, 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 lift. Again. Now, hold that. Nope, keep it held, okay? Now, breathe in your nose. Put the tongue up to the top of your mouth. 1, 2, 3. Breathe out through your mouth. Now, it's really hard for you guys to see, but we are really getting some good movement now in the rib cage. Again, pause. Where are you feeling that? Yep, we're getting it right here in this glute, okay? You can, some of your, you can relax. We want them to fire that glute, okay? As we do this, a lot of times what I will do is we know the right side's internally rotated, okay? The left side is externally rotated. So what I will do is I will do this activity on their left side to get that right glute to fire because I want to pull that pelvis back, okay? Because it's internally rotated on the right side. So I want it to be externally rotated, okay? I want, I'm not sure how much time I have left, but I do want to I think I only have 4 minutes. I really wanted you guys to have some demonstrations. You can go ahead and sit up for me. But these activities are not hard. If you want to take a few minutes and come up, and we up here to the front, I'll come down and we can do some demonstrations. I really want to say thank you to Yassine, who is the athletic trainer that I get to work with on a daily basis with our soccer team. And then the PRI Institute for opening my mind to a different concept and different approach when dealing with athletic injuries. And I want to challenge you as athletic trainers that when you guys are standing on the field, okay, when you're out standing on your field, try to practice getting in to that left stance weight bearing, okay, without leaning to your right. So we want you to do some twists, but really work on getting that. Ideally, we want you in a neutral position, but we want to make sure before we get you into that neutral position that we are able to facilitate your left side to actually do the proper pelvic position and turn off your right side. The majority of us are not able to turn off our right side. Are there any questions that anybody has? Oh. Okay. All right. Sure. Sure. What kind of post-rehab treatment would you recommend in order to prevent athletes from returning back to these misaligned postural positions? That's a great question. What we do is our warm-ups and our supplemental training actually is doing these activities. Okay, there's a whole slew of different postural positions, pelvic positions that we do and breathing techniques that we do with our athletes, but we do it when we have supplemental training, not when we're doing, our soccer training, okay? Very difficult to do in, I know, athletic type high school settings, college settings as well, but we are able to do supplemental training. And so if that is something that you could incorporate, and really and truly, I believe if you can get down to those middle school athletes and do some training sessions, a couple of times a month or whatever, and I know y'all are already very, very stretched, but I believe it starts early, okay? Because once you get to that high school, that college, that professional area, you're very set in that right side, okay? So the earlier you can get this out, the better, obviously. But again, the way we do this is we do a maintenance, and we do the breathing techniques and the pelvic postural techniques in our supplemental training. How often do you recommend doing repositioning treatment to correct athletes, and how many reps per session? So again, we talk about reps. I'm going to address that part of the question first. It's not so much about reps, but breathing. And so we always recommend 4 breaths, okay? And we may do it 2 to 3 times. In the beginning, when you have somebody that is so right side dominant or has a very exaggerated PEC chain, okay, you may only do 1 session of that one activity, okay, which is the 4 breaths, okay? When you get somebody lying sideline and they're doing a glute, firing that glute, I mean, within seconds, you'll feel that that glute is on fire. It doesn't take much, okay? When you get to doing the 90-90 hip shift, where you shift the hips and do the breathing on the balloons, that hamstring will start to cramp very quickly, very quickly. So it can depend how often. So we do supplemental training 3 times a week. So at our stage, we're doing it 3 times a week. And then anybody that is having, hip tightness, back pain, SI pain, impingement, anything like that, anybody that's recovering from, say, they have a calf strain or an ankle sprain or whatever, when they're coming in for treatment, we always do this in their session. So we do it when they're injured and recovering, okay? Because a lot of times you may have an athlete that's non-weight bearing, but you can still do a lot of these activities. I've had an athlete that's been with an injury to a spring ligament. And so he's been casted for 4 weeks now because we've tried the boot and it didn't do well. So the way I did this is I put the big exercise ball, because he can't put any pressure on that foot. So what I did is I have him do the 90-90 hip shift, okay, while on the exercise ball. So anytime, you're doing these activities, you can incorporate it in any time you're seeing some of these non-weight bearing athletes that cannot work out, okay? The next question, how often do you recommend doing repositioning Would you agree that if we train athletes to just breathe properly in through their nose and out through their mouth during training such as weightlifting, it would increase stability and less time for us to have to care for the athlete? Absolutely. Absolutely. I want to challenge you, instead of doing reps or doing an activity for time, that you do it with proper breathing techniques. So do 4 breaths. If you want somebody to do 7 reps, 7 good breaths. That's exactly, we don't count out how many reps. We focus on the breathing while doing the activity. How long does the treatment last for the athlete, along with how many times a day do you have to work with these athletes to see lasting results. I will say we do it, as mentioned earlier, anytime they're injured, so we may do it every day, okay? We encourage them to do these activities on their own, okay? Anybody that has positive PECs, such as like Ms. Anse here, another activity we like for them to do in the training room, even just they get there an hour before they have to be on the field. So we see the majority of our athletes coming in doing these activities on their own in the athletic training room, as well as downward dog. We love downward dog, okay? Getting them in that great position because they're overextended in their back. So in downward dog, we focus on them breathing and pulling in that lower abdominal. That is a fantastic stretch and warm-up for any of your athletes, okay? But how long does it last? It depends. How long have they been in this type pattern? How set are they in their ways, okay? Treatment, longevity, and how long will depend. But I will say I've had chronic hip pain for about 10 years. This year I've been really religious at doing these techniques. I'm able to fully weight bear on my left side, which originally when I was first going through the course and I did the demonstrations, I was not able to put all of my weight on my left leg without falling over, okay? So again, it also comes by lead by example. Practice these techniques. I really, really highly recommend that you look at the Postural Restoration Institute and go through some of their training, because it will open your eyes and give you a different approach to dealing with these athletes. One of the things that what I will see is I had a lot of our soccer players that came in for soft tissue work early on because they were sore, we were ramping them up and all that. Before we even do any soft tissue work, and we do a lot of soft tissue work, we put them through the pelvic positioning, we reposition, we facilitate, we inhibit. We do all of those things first before we do any tissue work. And the majority of the time, they will say, if you do one or the other, they'll say, well, it was okay. But when you put those two together, eventually you're not doing tissue work. They're coming in on their own and doing these activities on their own. But it also depends on the motivation of the athlete. Any other questions from here? I really want to thank you guys for your time. I'll be around for any questions that you might have. And I know we didn't get to fully demonstrate. I was a little nervous about the tables. But if you want to do some of the demonstrations and see for yourself or have a little bit of analysis,